It's a great pleasure that everyone's here. And actually, Etta and I saw the movie that we're about to show you a couple of months ago. Can't really remember when it was. And we thought it's absolutely fascinating, a really, really interesting movie. So we wanted to share it with you, and Claire was so nice to agree to it. So we're going to start with the movie. It's a short movie. It's only about 6 minutes, I think. And then after that, David, who's the expert locally at King's on OCD, will give you a talk as an introduction to the anatomical background to it. Okay? And after that, if you have any questions, feel free to just fire away.
Hey, how's it going? You well?
Fine. You?
Yeah, same old, same old. Excited about this match?
Yeah.
Biggest match this season, you're going to be hooked after this.
Yeah. So?
Got time for a cup of tea?
Yeah, definitely. Good idea.
So how you doing then? You well?
I'm fine. We square meals a day, do the bed, do the rest.
Yeah. Oh, hey! Let's have a look at this garden of yours now, see how they did. How long did it take them?
Oh, only 4 days.
You happy with that?
Yeah. If Father would have been pleased, I'd finally got round to it.
Oh, shit. Malcolm's forgot his ticket. Let's go around and pick it up. Let's go.
Waiting outside his house. Yeah. Don't know what he's doing. Okay, I'm gonna see the max, and there's a big one. Are you ready, sir?
1, 2, 3, 4. I just don't know how to fight you anymore. You've taken over my body and mind.
Dad, let's go.
You've made me your puppet.
Don't be like that. Just don't be like that. Right.
like an itch I have to scratch.
Like cutting keys. Just come on.
But the more I scratch, the more you make me doubt. You've never had a grip on me as tight as you do now.
Dad, what are you doing? Dad, come on!
Sometimes I think you could choke me if you really tried. One, two, three, 2, 4, 3, 5, 4,
Dad, it's locked already.
1, 2, 3, 4, 2, 5, 4, 5, 1, 2, 3, 4, 5.
Leave me alone! Just leave me!
Why can't you just wait for me like your mother used to?
Somehow I wish the film had been at the end, just to finish with a bang. Now it's the boring stuff. Just I thought that before going into the neuroanatomy side of things, I would start with a bit of an introduction about what OCD is. In fact, you could see it in the video in many respects. So the definition of OCD is that the patient experiences intrusive phenomena, thoughts or images or even sensations that are ego dystonic. So the patient doesn't feel that he or she wants to have these thoughts, and causing a great deal of anxiety and distress, fear. Because of these emotions being unpleasant, the patient feels compelled to perform repetitive behaviors to get rid of this anxiety, this discomfort. And what these do is they achieve a temporary relief. The person feels slightly better after having washed hands or checked the windows, or as you've seen in the video. But it's only temporary, and that's the key, because very soon the patient will experience another obsession, and the cycle will start again. And that's sometimes known as the vicious cycle of OCD, or the OCD cycle. One very striking feature of OCD, which I mention now because it will be relevant later when we talk about neuroanatomy, is that it's very heterogeneous in the clinical presentation. So the guy in the video had multiple symptoms. However, it is also common that people have one set of symptoms in one domain, like fear of contamination and excessive washing or cleaning, or thoughts about harming people or being hurt, leading to repetitive checking behavior, or the need to have things symmetrically organized and tidy and so on, and also difficulties discarding. So sometimes OCD is missed by clinicians because two patients may look completely different in their presentation. So some basic facts about OCD. Not so long ago was thought to be very rare, but now we know from from the 80s, 90s, we know that it's actually quite common, between 1 and 3% of the population, and has a similar prevalence and almost identical presentation all over the planet. And also subclinical symptoms, so these are people who have symptoms of OCD that are slightly impairing, but not to the extent that is required for a diagnosis. That's much more common, about 10-15% of the general population. It affects men and women in similar ways. It has 2 peaks of onset. There's a group of patients with an early onset in childhood, adolescence, and a second group that starts much later in the 20s. As the film mentioned, the WHO classes it as one of the top 20 disorders or diseases in terms of disability. It can be very severe and chronic if untreated. It has a great deal of comorbidity with a number of disorders, primarily depression, but also other anxiety disorders. And is often undetected, and this is because patients are often ashamed of their symptoms. They feel that they want to keep them secret. It's very embarrassing to go to your GP and say, "Well, I'm worried that I might be a pedophile and abuse children in the street, or I'm worried that I might take a knife and stab somebody." So this is something that you don't go and tell people normally. So it's quite secretive. And which is a shame because we have fairly good evidence-based treatments for OCD. We don't know the causes of OCD. We do know, however, that it runs in families. This is very clear. So first-degree relatives have about a 5-fold risk of having OCD themselves. And this risk is proportional to the degree of genetic relatedness. So, for instance, this is a large population-based study of 24,000 cases. You can see here that the risk for first-degree relatives is about 5-fold. The second-degree relatives, here in green, is about 2-fold. And for third-degree relatives, so that's first cousins, it drops to about 1.5-fold. So this pattern indicates that it's not only a familial but also likely genetic disorder. And twin studies have backed up this idea. So the number of twin studies looking at symptoms in the general population in large samples of monozygotic and dizygotic twins, and they converge to suggest that OCD is, let's say, moderately heritable. So about roughly 50% of the variance is due to genetic factors. So it's not as genetic as, say, autism or bipolar disorder, perhaps. It's also clear that unique environment, and that is environmental factors that involve one member of the family but not the whole family, are as important as genes. For example, stresses, traumatic events, infections, difficult births, etc. Whereas we know that shared environment, things that is shared by all the members of the family, are less important, like growing in the same family or expressed emotion or growing in a particular neighborhood. This seems to be less important. So that pretty much our knowledge ends there, because when it comes to identifying specific genes, we know very, very little. So there's been a lot of research on primarily serotonin, dopamine, and lately glutamate, but also other systems. And the results have been hard to replicate. Even except perhaps glutamate genes have been replicated in 3 or 4 studies. But generally, all findings, when you look at the genome-wide level, they tend to disappear. So even though the GWAS research so far has used very small samples in comparison to other disorders, I think the largest had 1,500 patients. But what is expected to happen is that there will be multiple genes, each with very small effects. And we'll need much larger samples to identify them. we know even less about environmental risk factors. These are very difficult to measure, and to do this properly, you would need a prospective longitudinal studies that allow you to look at, from very early childhood, to look at environmental exposures and how those increase the risk to OCD. And this research is so rare, there's only one study, in fact. But what this study suggests is that there's a number of fairly common stresses like perinatal insults, childhood stresses of different types, physical, sexual abuse, loss of a parent, changes in residence, that are implicated with an increased risk of OCD. There's also a growing literature on the so-called autoimmune hypothesis, whereby it looks like there are some cases of pediatric onset OCD that seem to be linked with streptococcal infections. But this is still very controversial. And all of these environmental factors, including the strep infections, all of these are very common, and yet people don't develop OCD. So it is quite likely that there is some gene environmental interactions at play. But we know very little about this. Okay, so that's the background. Happy to answer questions more general questions about OCD later if you like. But today we want to talk about the brain. So the idea that OCD might be a brain disorder is almost 100 years old. So people have suggested this many times in the past, but only kind of crystallized in the 90s probably. And when people started gathering various types of data, for example, the emergence of OCD type symptoms in neurological conditions of known basal ganglia involvement, like Parkinson's, Sydenham's chorea, etc. Cases or case series of brain lesion patients who developed OCD symptoms after the brain lesion. Evidence from psychosurgery that showed that interrupting certain loops led to improvement in symptoms of OCD and anxiety and depression as well. And obviously from neuroimaging, which is where most of the evidence comes from these days. So all of this together kind of led to the suggestion of a particular neuroanatomical model of OCD, which was very rapidly adopted by the field and taken as the absolute truth. That's what I call the widely accepted neurobiological and neuroanatomical model of OCD. And this comes from a handful of studies from the late 80s, early 90s, like this one. This is one of probably the first ones, using FDG PET, resting state PET, that found, this is Baxter in California, who found that people with OCD tend to have increased glucose metabolism in the basal ganglia and the orbitofrontal cortex. You can see here's more red than healthy controls. So a number of studies like this, all showing similar things. Then there was a next generation of studies, slightly more sophisticated in the mid-90s, using symptom provocation. So they put patients in the scanner and provoked their symptoms so they could be sure that what they see in the brain is related to the symptoms, and compare this with non-provocation conditions. And they kept finding pretty much the same thing. So hypermetabolism in the orbitofrontal cortex, basal ganglia, thalamus, and the cingulate. So I'm just showing you some examples of this, but there are many others. So at this time in the 90s, it became quite popular to talk about multiple parallel segregated frontostriatal loops. This work by Alexander and others on monkeys. So this was rapidly incorporated into the OCD literature, and it was at this point it was very clear that, or people thought it was very clear that OCD is about something abnormal in the relationship between the ventromedial prefrontal cortex, cingulate cortex, thalamus, and basal ganglia, and these reverberating loops that were abnormal in OCD. And since the 90s, there's been a huge amount of literature using different modalities of neuroimaging, structural, resting state, you name it. This is, for example, a summary of a meta-analysis of voxel-based morphometry studies in OCD, published up to 2009, that found very robust abnormalities in the basal ganglia. So increased grey matter in the basal ganglia, very robust, and reduced grey matter in the dorsal prefrontal or cingulate regions. Interestingly, nothing in the orbitofrontal cortex, which is what was been suggested until that time. And also note that these findings, this come from whole brain studies that are not biased by the investigator's hypothesis. So this is what happens at the whole brain level. And these regions happen to overlap with the same regions that are the targets of psychosurgical interventions for OCD. So for example, this bit here, anterior capsule, so that's the target for capsulotomy or deep brain stimulation more recently. And that corresponds exactly with the target of another common psychosurgical intervention called cingulotomy. So those bits of the brain are clearly important in OCD somehow. And then there's a number of molecular imaging studies that appeared. This one, for example, shows dopaminergic abnormalities in the ventral striatum, which again would support this striatal model. And in terms of dopamine, so the widespread reductions of receptor availability, primarily in dorsal cortical regions, but not only, but also temporal regions and parietal regions, but not in the orbitofrontal cortex. So if you put all of this together, this has led to a kind of a revised but even more accepted model of OCD, and it's a bit complicated, but essentially it postulates that there are primarily two of these frontostriatal loops that are involved in OCD. One is this ventral prefrontal loop, primarily the orbitofrontal cortex, connecting with corresponding subterritories of the basal ganglia, ventral, caudate, etc., thalamus, and going back to the ventral prefrontal cortex, which would be hyperactive, and a dorsal prefrontal loop, which connects with the corresponding dorsal subterritories of the basal ganglia, which is hypoactive, so it doesn't do its job properly. So it's an imbalance between these two loops that would be responsible for the symptoms of OCD. So, is this accepted model acceptable? Well, I think people are starting to move on from this. So we've had a bit of a tunnel vision, and we've been concentrating on this frontostriatal loop, but probably there is more to it. First of all, this is segregated parallel loops. Maybe they're not as segregated as we thought they were. And they seem to communicate a lot more than it was thought in the 90s. It looks like other brain systems other than the corticostriatal systems might be important in OCD. For example, the limbic system has been totally neglected. It's not that it's not important in OCD, we just haven't looked at it because we're so focused on this corticostriatal approach. Then we also know that, as I said at the beginning, the disorder is highly heterogeneous, not only in the clinical presentation, but also in the etiology. We know that from twin studies. So if it's etiologically heterogeneous, one would not expect a unitary neurobiological substrate. And finally, we're very far away from understanding the causes of these abnormalities. Whatever the abnormalities are, we don't know what causes them. So just briefly talk about each of these things. So DTI has become popular recently. Mark can tell us a lot about this. And there's a surprising large number of studies that are beginning to appear in OCD. And what they show, for instance, and this is a meta-analysis we're working on of DTI studies in OCD, that shows that implicates, this is very preliminary, but it implicates not only frontal white matter tracts, but also visual and parietal white matter tracts, which fits with a number of other studies that are now implicating frontoparietal systems involved in different cognitive functions in OCD, not only the frontostriatal classic system. How about the limbic system? Now, people have started to look at it properly using paradigms that can actually answer questions about the limbic system. And it turns out that the amygdala, hypothalamus, and so on, hippocampus, that didn't show up in the previous literature, all of a sudden it starts showing up because we're using the right paradigms. So this is, for example, a study using an emotional stroke task with OCD words and showing increased amygdala activation in OCD compared to other healthy controls, people with panic disorder and people with hypochondriasis. So it seems to be people with OCD respond specifically to OCD-related words in the amygdala. So what's happening now is that people are starting to come up with more complicated models that go beyond the basic model. For example, incorporating the classic ventral prefrontal loop with more limbic and paralimbic regions, and trying to understand how those frontostriatal and frontolimbic systems interact, and also incorporating the fact that other systems, like parietal systems, dorsolateral prefrontal cortex, and other, the more cognitive dorsal loop that has been totally ignored in OCD so far, is becoming important all of a sudden. So people are trying to come up with ways to understand how these systems interact. And of course, there's the heterogeneity. So there's a number of studies now. This was the first to use a symptom provocation approach to see what happens in the brain if you provoke different types of symptoms. And the bottom line is that each of the different each of the different symptom provocations leads to different patterns of brain response. And there are a number of other studies now, including structural imaging studies, showing that each symptom dimension of OCD correlates with different structures or abnormalities in different structures of the brain. And there's one particular study I'd like to show you because I really thought it was great. This work by a Swedish group who have a very unique sample of patients who underwent capsulotomy for OCD many years ago. They don't do this anymore because it was obviously too invasive. The 24 patients who had severe OCD and tractable OCD, and they were essentially had lesions in the capsule, ventral striatum, and followed for 10 years. So then we looked at how patients with different symptom presentations fared with this treatment. And it turns out that people who have symmetry and order symptoms, like you've seen in the video, doing things in particular numbers, wanting things straight and so on, these patients do not respond whatsoever to this intervention. So if all OCD patients had a unitary neurobiology, if all the symptoms could be explained by a simple brain system, you would expect everybody to respond the same, and it's not the case. So this is a very bad deal for them to take the risks of an operation like this for nothing. And finally, the biggest question of all is, imagine we work out the neuroanatomy properly, then what causes these abnormalities? So there are two options, at least. Do these abnormalities precede the onset of the symptoms? Are they something you're born with, and that they're like vulnerability factors that increase your risk of developing OCD? There's some literature emerging showing that first-degree relatives of people with OCD who do not have OCD themselves may share some of the abnormalities, but this is very small literature. On the other hand, it is possible that some of these abnormalities are just the consequence of a chronic illness, of many years of suffering with this, stress and so on. And there is evidence that some of the abnormalities are reversible with evidence-based treatments, so with antidepressants and behavior therapy. So the brain becomes normal after these evidence-based treatments. To me, these two lines of evidence are totally contradictory. So which one is it going to be? Are they there before, or are they reversible? We don't know. So, just to conclude, multiple systems are probably involved in OCD, not only the classic frontostriatal systems. Each of these systems is possibly implicated in different aspects of the psychopathology of the disorder, or the cognitive deficits associated with the disorder, and possibly interact in very complex ways. A single underlying neurobiology for OCD, the way we define it today, is probably something that we will not achieve, simply because what we call OCD is made out of many different things that we group together because we don't know better. And finally, the causes of these abnormalities are unknown, and we will need to change chip, and we will need to come up with cleverer designs to get closer to that, like genetically or etiologically informative designs, like discordant monozygotic twin designs, longitudinal brain maturation designs, etc., etc., in the hope to get a bit closer to that question.
First of all, big thank you to the two of you for having us show the movie and for the great talk. I would start with questions from yeah.
I mean, what about the story that there's again your overactive and poorly controlled by hyperactive frontal lobe, which is in line with your meta-analysis of people that's again on the PET study showing too much dopamine, like and not enough serotonin. Is that no longer acceptable?
Well, this has been suggested, and it makes sense to me. So I was alluding to the fact that the dorsal systems have been totally ignored, as if they were not important in OCD, even though they showed up here and there in different studies, and people try to ignore them because they don't fit. But it seems very plausible to me that this idea that there's a failure of dorsal systems to control both the limbic and the subcortical structures in general. That makes a lot of sense to me. And in fact,
I always thought that was a sort of common hypothesis.
Well, it is. I mean, there are a lot of people who believe this is plausible, but this is quite recent that people have begun to accept this idea. Before, people were very, very focused on this ventral hyperactivity findings.
Yeah.
Question for which one of you? So one thing is that David, you kind of resisted or avoided consciously the fault network kind of hypothesis. I mean, nowadays this default network hypothesis is involved in everything, from OCD to autism, etc. And it kind of you can see why there is these dorsal connections between precuneus and those anterior cingulate medial frontal cortex, and people think, well, actually, if that default network remains kind of a hyperactive or active, you are kind of locked into these neuro-obsessions, etc. What is your view on the default network and OCD, or there is any hard evidence?
Well, I didn't mention it because there are quite a few studies using this idea. So people are more frequently using resting state neuroimaging, but not in relation to the default network, but using seeds that are usually located in the basal ganglia, surprisingly. So so there are a couple of studies looking into this, but I'm not sure that they show a consistent story yet. But if they did, what would we learn about OCD? I mean, wouldn't this be something that happens in all mental disorders? And what would we? I mean, would we learn anything specific about OCD? I'm not quite sure.
Another question for Claire. I mean, in my experience, having worked with some OCD patients, especially there's a kind of an overlap between autism and OCD. In the general kind of population, the idea is that OCD patients are quite young. So, but you choose for your movie like a relatively older person, and I wonder, where that idea comes from.
The choice to have an older person, I'm not entirely sure why I had someone older, but I've been an OCD sufferer for about 10 years. My dad suffered with it as well, quite severely when he was younger, and he is also bipolar, and that whole side of my family have severe anxiety, and I think I have a very strange relationship with my dad. We're probably only really in contact because of our shared kind of problems, and I think this was almost, I didn't want to tell my story, I wanted to sort of maybe tell his instead. So yeah, I think maybe that was sort of subconsciously what was going on, but I can't really say that I had a plan as to why that was. It just seemed right when I thought about it. It just seemed that was the right age to go for.
I think it's a good choice in the sense that people perhaps assume that OCD is something of young people, but in fact it affects people of all ages.
Yeah,
so I think having a more senior citizen was probably quite a good idea.
I think it's quite interesting to sort of look not just at what's happening to someone with the disorder, but what effect that has on people around as well. Because with not just with OCD, but with any sort of mental health issue, obviously that individual will go through suffering, but the burden that those people put on sort of onto everybody around them, as a friend or a carer, you don't really get told how to deal with that. I was never really told how to deal with my dad when he told me he was suicidal, and that's just something you have to sort of take on yourself and deal with. So I wanted to have that kind of relationship between actually the realisation of this isn't just someone being silly, this isn't just someone needing to do these things. The one thing that really gets to me is when people throw the term around and say, oh yeah, I'm a bit OCD, or my friends are a bit OCD, and God, wouldn't it be good if everyone was OCD because everything would be really neat and tidy, and obviously there is humour and everything, but for someone who suffered quite severely from it and has had depression and been to some very dark places, it's not something that you can really often see the funny side of. And OCD is just so far from being neat and tidy. It's about literally tormenting yourself every single day and hiding it as well, having to hide it from everybody else. It's not just that you've got a broken leg, you can't just go, oh yeah, I've got a broken leg, and everyone goes, oh, poor thing. It's, we can't even talk about it, which is absolutely ridiculous. Can't even talk about it. Sorry, I'm going on a bit of a rant.
I have a comment rather than a question, Claire. You did it very well, very elegantly, and what I did like the most in your film, you gave hope in very gentle, in very good way with this hug, how you finished it. So it was really well done. I see lots of people with anorexia who have lots of OCD comorbidity as well. And I was thinking for myself, I'm doing recovery group in one of the programs in our service, and it would be really nice for my patients to see that film. So really well done.
Oh, thank you very much. Thank you. Yeah, I didn't want to have a happy ending, as it were. Didn't want to
Yeah,
have a
which
kind
is
of someone
gentle,
being cured,
yeah.
because that's not the reality of it, I'm
Yeah.
afraid. You know, it is just some, you know, it's...
That's what I like.
Yeah.
Support and sort of good, positive attitude. That's how it matters. This is the whole.
Thank you.
Can I just you know, being yourself an OCD sufferer or having been a, does it help to know that actually OCD has an organic or maybe has an anatomy? So it's something that could explain some of your father's symptoms, for example. Does it help or doesn't matter?
It does, because there's been times when I thought I'm actually crazy, and it is kind of almost comforting to say it's not. You do feel weak sometimes with when you have OCD or depression or severe anxiety, and then you have panic attacks. You do feel like, why can't I just pull myself together? Why, you know, people will turn around to you and say, just don't do it, just stop checking, just don't do it. And I know that physically, yeah, I could just not check that. Physically, I could just hold myself back, but I can't. That is so frustrating. And so to know that it could be something actually going on there, it kind of, yeah, gives me kind of almost an excuse. Yeah, almost an excuse. But I've tried different therapy. I've tried counselling, CBT, medication, alternative therapies, meditation, support groups. Tried quite a lot of things, and I have found most benefit from medication. Definitely.
I was wondering, are your father's symptoms similar to the symptoms you have? In the sense that David was saying there's these differences, checking and there's organs and different things. Do you have similar symptoms?
Yeah, well actually, interestingly, my dad developed his OCD when he was very young, and he had a trauma. His father passed away quite early on in his life. But my dad's symptoms were symmetry. Really strong symmetry. You know, he told me that he'd go out to school and he'd spend an hour in the morning lining things up exactly where they should be, and he'd come home from school and go into his room and he'd look and he'd go, my mum's been in my room, and there'd be one thing out of place, and then they'd have a blazing row about, you know, why she'd gone in and, you know, how dare she touch his things. I don't have, my mum would tell you, a problem with tidiness, and you know, I don't have to have everything neat and tidy. But we are both very anxious, and we both have slight contamination OCD as well. But my OCD is predominantly checking and violent thoughts.
Because it's interesting from a genetic perspective, because you were showing that different areas become activated with different symptoms that genetically different parts of your brain.
Yeah. He does. I mean, my dad went on. He was only diagnosed as bipolar about 15 years ago, and he was put onto lithium, and his OCD just went away like that overnight. He said it just totally went away. So that's sort of maybe a nice thought. Yeah.
Sorry for that. So interesting. I can't really refrain. But they're just linking up the anatomy with what I was saying about. So it's not kind of surprising maybe that some of the OCD patients, or most of them, have some activation of some brain abnormalities that overlap with people with depression, for example, or anxiety, etc. So I wonder how much of the revised extended model is made up of a core characteristic abnormalities of the OCD, and the rest maybe is due to some other implications, the anxiety that comes with it, and also just a brief comment. the first PET study that you show, there's a quite increased activation of, or increased metabolism, glucose metabolism of the insula, which maybe was overlooked.
Yes. It might well be the case, because comorbidity is the norm in OCD. So it is finding a person who has OCD and nothing else is very, very difficult. Depression being, or mood disorders being very, very, very common, anxiety disorder. So it might well be that all this is noise that is introduced in the studies. But yeah, I mean, it is possible. I mean, no one claims that, or at least I don't, that this neuroanatomy is exclusive to OCD. In fact, it is. There's only one brain in a way. So, and probably all of these disorders, quite a few of them, share the neuroanatomy, don't they? So, it would be a mistake to think that this circuitry is only exclusive property of OCD, and that's it.
I have one more question. Did you actually show the movie to your family and your friends, and how did they respond to it?
I showed my family reluctantly. I can't actually, I said to you, I can't bear to watch it anymore. They didn't really respond with anything significant. I'm very open with my family about it, about everything. I mean, I think because my family all suffer from something, eating disorders, anxiety, social agoraphobia, bipolar, OCD, it's sort of everybody is quite open about talking about the problems, and I think they were quite shocked as to how much of it is internal, because obviously anybody that doesn't have OCD only sees the exterior elements of it, so they'll only see the physical elements of checking or putting things away or straightening things or cleaning. And what I really wanted to get across was those things kind of second in the whole thing. The real trauma of it, the real trauma of having it is what goes on inside. So I think they were, if anything, they were quite sort of, it made them realise what goes on in my head a little bit more, which is only a good thing, I suppose.
Any more questions? No? In that case, thank you again.
Thanks very much.
And yeah.